Well, here we are, the closing keynote of Connected Health 2015, and I am thrilled to invite to the podium my supervisor, my colleague, my friend, Gregg Meyer. I first got to know Gregg a few years ago when he was the medical director for the MGPO, the Mass General Physicians Organizations. After that, he was asked to build from scratch the current quality and safety effort at the Mass General, which is quite impressive and still stands today from his original building. It has his fingerprints all over it. He took a sabbatical, we like to say, and ran the whole, he was a chief medical officer at Dartmouth Hitchcock for a couple of years, and then was recruited back early in 2014. And as part of that recruitment, took Connected Health under his wing. So we've had the pleasure of working under Gregg for just almost 2 years now. And it is a pleasure to bring him to the podium to talk about the chronicles of a delivery system in flux. And it's really about how we are evolving in this crazy world of fee-for-service and risk and what that means for systems and connected health, and I know you'll enjoy his talk. Welcome, Gregg Meyer.
Thanks, Joe. Thank you. So I think all of you deserve a special prize for being here and sticking it out for this long. What I would like you to think about is I'm hoping that you're not going to be trapped into one of the situations that is part of one of my favorite stories for this time of the year, and that is, the Charlie Brown Halloween, the Great Pumpkin. And as you remember, that when they go trick-or-treating, they go up to the front door and they go trick-or-treat, and Lucy looks in her bag, and she's got like these Reese's peanut butter cups. She's like, wow, that's like hearing Zeke Emanuel, right? That's really a great treat. And then Linus goes up and he looks in and wow, he's got M&Ms. And so that's like hearing O'Neill Britton. And the next person goes up, and Pepper and Patty goes up and she looks in her bag and she's got these great lollipops. And Charlie Brown goes up and he looks in his bag. He got a rock. I don't want to be a rock. Okay, I want to be here to kind of close things out and put things in perspective. What I want to do is I want to share a little bit of a dilemma, and the dilemma is kind of what I face as a leader in a health system trying to think about telehealth. And I kind of reflect back very fondly on being present at the first Connected Health conference. And I can remember going there, and I thought, I walked through the exhibit hall and heard heard the presentations. Wow, this stuff is really cool, really cool. I just don't know what I would do with it. Really cool, I don't know what I would do with it. And at the time, there really wasn't a will or a way to move that forward. And I want to give you a little bit of historical perspective and talk a little bit about the past, a little about what's going on today, and a little about how I think we're at an inflection point right now on where we're going in the future. And so just to start, to put things into perspective, this is a little bit about Partners Healthcare. We take care of about 1.5 million patients each year. We have 6,500 physicians, the vast majority of whom are seeing patients, many of whom also spend a significant amount of time doing teaching and research. We have about 64,000 employees, and we're somewhere between $11 and $12 billion in total revenue. So we are a relatively sizable health system. We have a very long history of innovation. So we really are quite proud of the fact that just last week we celebrated Ether Day at Mass General. That was when the world was freed from pain. We can talk about how the Brigham did the first successful kidney transplant, which was really extraordinary, and some of the work that we've done in the past in this space and related spaces to CPOA. And one of the things that we probably don't talk enough about, though, is actually the history of telehealth. And in particular, going back to the 1960s, and Dr. Kenneth Bird, when he set up his telehealth apparatus out at the Logan Airport to be able to take care of patients remotely from the Massachusetts General Hospital. And although it's only separated by just a couple of miles as the crow flies, it was actually quite difficult to get through that tunnel. There was a single tunnel back then and get to the Mass General. And he came up with this notion of maybe we can take care of those patients who have chest pain, who are short of breath, who have an acute problem. Maybe that we as providers, that we're going to be able to project our care over there. It was a really revolutionary idea, really extraordinary. And when you think about how they did that, at that time, the technology, it was really high tech. I mean, this was really, really cool stuff. And they had these huge arrays of electronic equipment, and they had the cameras back and forth. This was really on the cutting edge. This was completely custom, put together just for this purpose. And by the way, it was pretty expensive. I actually think hiring a full-time RN as a camera person would be a pretty expensive thing to do. I would not do that today. When you think about what it is that they did, was that they did transactional services. They took care of things because it was active. We were doing something at the time. It involved the physician and the patient interacting with each other. And you can see here, they're reading an electrocardiogram on the bottom there. And these are stories from TV Guide from 1969 and the Boston Herald Traveler from 1969. Pretty neat stuff back then, but very small and very much a niche. And let's say, okay, well, what's going on now? What's happening at the present time? And when we look at the present time, the focus now isn't just on that acute care, it's convenience care. And you heard a lot about that today, and that notion of, wow, we're really transitioning not just from convenience care, but how can we use this for chronic care? And it's not just driven by the providers wanting to deliver those services, but it's delivered by teams. It's starting to be delivered by systems. And here you can see some of the things that are going on now at Partners Healthcare, thinking all the way through, all the way through from how we deliver healthcare in our hospitals, how we link up with our urgent care centers, how we use kiosks, some of the wellness protocols, using things like Wellocracy, using some of the monitoring systems that we have. And this stuff is working. You can see some of the data from our congestive heart failure program down there in terms of the impact that we've been able to have in terms of the percent of enrollees and their readmission rates. So this is real time, it's working. But by and large, we are still relying on relatively high-tech stuff. They're now niche produced. They're not custom stuff anymore. You can get this off the shelf, and the good news is that it's getting cheaper. And as opposed to this being the means that we deliver care, that we had to go through this TV channel to get out to that patient at Logan Airport, it's now a tool. It's now becoming the blood pressure cuff. It's becoming the scale. It's now just another part of our armamentarium that we can put on it. And we're going at this pretty strongly across partners. You can see here the various areas that we're thinking of. How do we deliver these services to the patients that need them? And on the one part, there's the synchronous virtual visits, and we heard a little bit about that in the last session, and the store and forward stuff on the right. How do we do virtual consults? How can we actually have a physician talk to a physician somewhere else and provide that consultative services? And how can we do that in a synchronous and an asynchronous way? And we are doing work in all of these. And when I look across what's going on right now at the Mass General, at the RIM, and through Partners Connected Health, we've covered that waterfront pretty successfully. But here's the problem. This is a list of what we at Partners Healthcare say, these are our cross-cutting programs. These are the chips that we're laying on the table and saying, here's how we're going to move into the future of healthcare. And you can see that we're putting a lot of emphasis on our population health management infrastructure. Partners eCare that O'Neill just talked about, our investments in Epic. Community health and graduate medical education. We need to do some work on cost management and research management. Telehealth's not up there. Telehealth's not up there, right? So we're doing it, but is it really a really hardcore strategy? And why? Why is that the situation? And I think many of you know this well. That when we think about how do we actually scale this right now, there are still a number of barriers that are out there. And so part of it is getting our providers to use it. They're quite busy. How can they start to see that this isn't just something else that they have to do, but actually this is a substitute for other tasks? And by the way, that this is easy to use, that it's very, very effective, it brings them satisfaction, and oh, by the way, they can feel really great about the patient care they delivered. How do we make that happen? On the patient side, how do we make this easy for patients? How do we make it so it's not so scary, that it doesn't require a PhD to set the equipment up at home? How can we make it really easy? On the technology side, I think many of you here in the room are solving that. And I think that that's probably the least of our worries. And I have to say that when I think about where we are at in this inflection point as a system in flux, I would say that that's the one I worry about the least, because you're helping us solve that really, really quickly. The financial front is who's going to pay for it. Earlier today, some of you had a chance to hear Zeke Emanuel, and Zeke talked about the fact that there is this bear in the path, and the bear in the path is saying to you, I get paid for doing what I've always done in the past. You're saying, here's this new way of doing it, but no one's coming forward to pay for it yet. And so how do we get over that important? Finally, the regulatory piece to all this. And so when I think about what's coming, the late, great Yogi Berra, it's tough to make predictions, especially about the future, but I'm going to share some predictions with you. And the first prediction is that I think that this is a great time to work in healthcare. And Zeke and I were reflecting on the fact that we first met 23 years ago. We were part of that evil cabal of people who worked behind closed doors in the White House on what they call Clinton healthcare reform. Well, that was a really big swing and a miss. That didn't work out so well back then. And yet we were both saying, when we reflect back on that, it's amazing how little changed in the first 19 or 20 years. What's happened in the last 3 years is really amazing. It's really amazing, and it's an exciting time. And I do think that we are now at this inflection point. And why are we here? And I think when I try to think through that, I always think back to high school biology. And what I think about is the butterflies here. What you learn in high school biology when you learned evolution is that the way that we get new species, there are gradual itty-bitty mutations that over generation after generation and over the course of eons result in new species. And that's called gradualism, Professor Dworkin's theory, and derived from Darwin. But the truth is that when you look at the fossil record, as Stephen Jay Gould did in the 1950s, every now and then you find butterflies that look like the right. That you have this incredibly rapid change, this new speciation coming over a very, very short period. And that is not because the butterflies changed. They didn't become more genetically unstable. There was no other change to butterflies. What changed was their environment. Their environment created a set of conditions that conspired for rapid change over a relatively short period of time. And that's called punctuated equilibrium. Right now, in healthcare, we are in a punctuated equilibrium. What does that mean for us, and what does it mean for telehealth? And I think the use case is getting very strong. And so for many of you know that CMS has been putting more and more emphasis on their value-based purchasing, their pay for performance. It is not trivial when 6% of payment to American hospitals and physicians is going to be at risk in FY 2017. So wow, there's all of a sudden this impetus to keep patients out of the hospital. And so the tools that you've made to help me with readmissions, wow, that becomes really valuable all of a sudden. But what many people don't recognize is that there was this thing called the SGR, the Sustainable Growth Rate, which was a formula that dictated physician payment that was part of our legal landscape for over a decade, which really dictated that we had to drop physician rates very quickly. And many of you have heard that there was the, quote, SGR fix. Earlier this year, Congress, in a kind of rare spate of bipartisanism, actually got together and fixed the sustainable growth rate and replaced it with what's called the Medicare Access and Child Health Reauthorization Act, or MACRA. The important point about MACRA is that what that is forcing right now is that the new payment models, you're going to have two choices going forward. One is going to be a merit-based incentive payment system, or the MIP system, which essentially says, we're going to bundle together your ability to adopt healthcare technology, what we used to call meaningful use, and how well you do on value-based purchasing, and how well you do in terms of getting certain healthcare outcomes. And by the way, by the time this program ends, that you're going to be facing a 9% penalty, potentially, or maybe an upside up to 27%. Based on your ability to perform in those areas. But there's a really important piece here, and that is that one bit of data on top that says from 2026 on, only about 1/4% of what Medicare updates, the increase in Medicare payments, is going to go through this mechanism. Most of it's going to be channeled through the alternative program. The alternative program is to say, nope, we want to get paid on an alternative payment model. We want to get paid in an ACO structure. We want to get paid through a Medicare Advantage type structure that puts us more at risk. And when you look there, that's where 3/4 of the update money is going. What the federal government is doing is they are not right now creating a very strong incentive that is going to push everybody over time into risk situations. People are going to have to start to consolidate, and the physicians are going to have to get together with large health systems and start to work together to be able to take on this kind of risk. This is a game changer. We're not talking about it enough. And what that is going to do is that is really going to force all of us to say, how are we going to get to this nirvana. And the nirvana here would be in the upper right quadrant, and that is that we're going to be able to do well on risk, we're going to be able to do well on global capitation, and we're going to be really integrated. We're going to be able to take care of those patients seamlessly for all their needs, cradle to grave, from self-care all the way through to high-tech care and back through home care at the end. And so where most of American healthcare now is down that lower left corner, relatively fragmented, working in a fee-for-service model. Where many of us have moved to is we've made those advances in integration. So you heard O'Neill talk about what we're doing with eCare. We're paying to create the integration across our system right now. That's where many academic health centers are, and they're very happy to take their fee-for-service. And again, Zeke talked about how many of our colleagues around the country are saying, let's just stay right here for now and keep working on fee-for-service. The lower right corner is a pretty uncomfortable place, and I think that's probably where managed care was in the 1990s, where people took on lots of risk, but they weren't integrated enough to manage it. So we want to get here, but here's the problem. You can't jump straight to the upper right quadrant. You've got to say, I'm going to make an investment in integration. I'm going to start to put money into things like telehealth and make it a real strategy now, knowing that I'm not really going to be able to get paid adequately either on my risk contracts or on a fee-for-service transactional basis for providing those services. I'm going to do that now because it's going to get me here. Or you say, I'm going to go ahead and take the gamble. I'm going to take on a lot of risk and hope things work out. And what we're trying to do with partners is we're trying to go that upper route. We are trying to move over to become more fully integrated and to be able to take that risk in a safe way by making investments now, knowing that we're going to lose money. We're going to lose money on doing this. And so when you think about that, and think about the tools that you are all bringing us now. So the focus now is becoming someone health maintenance, monitoring, patient engagement for chronic patients, adherence, the ability to do population health management. One of my favorite tools here is on the right side. This is work from the North Shore University Health System in Evanston. And what you can see is they're looking at their electronic health record from the day before. They're collecting data from patients via web apps, and they'll be able to monitor, for example, a gastroenterology illness outbreak, or to be able to monitor influenza in this case, and map it and make it available to primary care doctors now under a very sophisticated name. It's called What's Going Around. Right? A great tool for someone like me, a PCP. The equipment is high tech still. It's really cool, but it's ubiquitous. It's everywhere we look. This is starting to become just part of our landscape, and it's getting relatively cheap, and it's becoming a more and more disruptive substitute. And so putting these pieces together, and I'm not going to go through these models because you've heard from some of these folks over the course of the last few days, but I think the economists had this just right, is that right now there are many companies that see the disruption unleashed by the reforms. So the combination of the will comes from the fact that, wow, we're being pushed into these risk arrangements. Population health management no longer becomes something nice to do. It becomes essential for us to do well. And by the way, also we have the way to do it. We have the tools that all of you have been helping us develop over time, that's being seen, according to the economists, as the business opportunity of a lifetime. So where does that leave me? That leaves someone like me who's trying to make decisions about a healthcare system. I'm trying to say, when is it that we make that transition? And the transition here is, when do we go from what I would call a wonderful series of science projects, great proofs of concepts, letting 1,000 flowers bloom. And it's a really wonderful thing to see. And when you go out and you go through the vendor space here, or hear the wonderful things that are brought to us by the Center for Connected Health at Partners, it is a wonderful thing to watch, but it begs the question of, when is it time that we really start to tend to the garden? When do we say, nope, we're going to go from 1,000 flowers blooming, say we're going to have a little bit of on the bottom there's a little bit of an unruly garden to start with, but it's well tended, and it's really moving us over from science projects to strategy. Now's the time. So when I look back at what we're doing at Partners Healthcare and our centralized and cross-cutting programs, in the past we had to say, why should telehealth be there? I think the combination of the tools that you've built, the fact that they're becoming ubiquitous, the fact that they're becoming passive, the fact that they're becoming easier to use for our providers, our patients, and they're drawing us together in ways that we never thought would be possible, combined with the The fact that we now have to do well in risk arrangements, and oh, by the way, many of those barriers I talked about before are starting to fall by the wayside as you think about the new way we're going to be delivering care. Now is the time when we say, why not? It will be on this list in the future. So caution on all this. Foresight, those who say it cannot be done should not interrupt those busy proving them right. I hope I'm not one of those proving them right, but we have faced a lot. When I think back again, walking through the first Connected Health Symposium, really cool stuff, but I don't know what I would do with it. When I walk through Connected Health now, say, really cool stuff. Some of this I have a good idea on what I would do with it, particularly the stuff related to chronic care. And oh, by the way, I got to figure out how to use it. The world's changing. Thank you.
Well, I promise you I didn't pay him to say it. But that is a great segue into my wrap-up, and I only have 50 slides, so don't worry, it won't be long. I will be succinct because it's been a great 2 days, and I know everyone who's stayed, again, you all deserve a medal, but you have things you want to do and places you want to go. I would say the first thing I want to say is that we exceeded this year by every metric how we did last year. We have more attendees, we had more exhibitors, more sponsors, so I think that says something for the health of the conference, and again, it's a tribute to all of you because none of that would happen if we didn't have interested participants, so we appreciate that very much. I also can't resist again asking you all to give a round of applause to my staff, the staff at the Center for Connected Health. I have the privilege of going to a lot of meetings. I speak all over the world about our work, and I can tell you objectively this is a very well-run conference, and I'm very, very proud to be associated with the team who puts this on. We're starting Monday to plan for next year, so take a breath over the weekend, but this is a year-long effort. Now, someone asked me upstairs, a reporter, about an hour ago, what did I learn? What's the headline from this year? And it's such a rich, rich experience over 2 days that it's hard to pull one or two things out. But it comes back to our themes. One theme, that it's becoming part of mainstream healthcare delivery. And you have the example of Robbie Pearl from Kaiser talking about their millions of virtual visits, that in a couple of years virtual will be more prominent than face-to-face in their system. You have the wonderful work that was talked about in 2 panels back by the guys from the virtual visit space. Gregg's talk about how we're going to have to move in this direction with authority in the next months to years, all speaks to the fact that it's time to scale this activity, and it doesn't come a minute too soon for me, I'll tell you that. The second thing I would say is really what, and again, the Internet of Healthy Things is an interesting turn of phrase, but what really came to me over the 3 days, including Wednesday, was this idea that wearables are moving beyond something that just tracks something. And you're getting a read on your stress level, or you're getting a read on your emotional state, or you're able to predict when someone's going to have an epileptic seizure, or you're starting to get a different second dimension to this whole wearables thing, and that's pretty exciting to me. I'm thinking that maybe we'll have a bigger presence of that on next year's program, because it's this whole brain-computer interface and emotional sensing. All of it is really exciting, and it's going to be really necessary that we figure that out to move us to the next level. So again, I thank you all for your loyalty, support, for coming out. It's been a great couple of days. Have a very good ride or trip wherever you're going, and safe travels and a good weekend. Thank you very much.